Hi, everyone. This is the San Francisco PDA Student Chapter podcast for August 21st, 2020. This podcast here is with Nick Kapp, student advisor for the San Francisco Student Chapter of the PDA. We are doing this in front of a live audience, and you can see some of the people stage right on our audience. This is a series of podcasts from 5 to 10 minutes long. What we intend to do is we intend to inform and educate a new generation of pharma manufacturers through a discussion of helpful links, stories, and interviews. In the future, help us help you. So in the coming weeks, we'll be trying out various ways to do our listeners. Today, we're trying a live audience. Let us know what you think. As always, we are part of the Parenteraldrugassociation, connecting people, science, and regulation. I'm Nick Kapp. Again, right now for COVID-19, we do not have a vaccine. Right now, as of 8/21/2020, we have over 5 million cases in the United States, and we have 173,000 deaths. This is a public health disaster. The CDC has been really good in developing guidance for actions to slow the spread of disease and to lessen its impact. And I have a slide up here, people kind of washing their hands help. So again, wearing masks, social distancing, shutting down and sheltering in place have worked pretty well. In the CDC, we are studying, identifying, tracking, and monitoring our way out of this. In an interview at Politico this month, Dr. Fauci has talked about half the tests are useless in terms of public health. The health experts said that in recent delays, sometimes lasting a week or more, have rendered the tests largely useless in terms of a public health perspective. The gold standards for the SARS-CoV-2 test is still a PCR. But again, in that PCR, we get 30% false negatives. And to move this a little bit, but when they put that little swab up in your nose, depending on kind of where they go, they can get some of the materials. And so even professionals don't do that right. Trouble is with this also is professional and academic labs are competing for the materials, the swabs, the tubes, and everything else that they use. It can take up to a week to get your materials back, and the materials can actually cost up to $100 a piece to do that, which doesn't seem like a amount of money, but it is. We need cheap and easy testing. Sorry, it says east here. The lateral flow assay is a typical test that we have where it's simple to get the test. And so these are those pregnancy test strips. And what you see is you put your material inside of a sample, saliva or some other type of sample, and that material moves through, and the lines that you get up here determine whether you have done that. This test can be done at home. You get the answers at home within 15 minutes, and it's very cheap. It costs less than $1. Again, it's less than a latte to do these tests at home. So we can do those tests every day, every other day. And, again, we look at this, even if it misses one day, then you're still going to be testing the next. People talk about the reliability of these tests. Like we said before, if you don't get it one day, because you're doing your test every day, you're going to meet that during the next day. Some of my results here that I'm looking at, I got from Dr. Michael Minna, MD, PhD, and he does a fast test discussion on YouTube. You can see the links down below. But basically, when we're looking at the COVID-19 test comparison, when we compare the paper antigen test that I showed you the picture of the strips, like the pregnancy test, or the reverse transcriptase PCR test, a big difference is the cost, approximately $1 for the paper test, $35 to $200 for the PCR test, average about $100. The paper antigen test is very rapid, taking about 15 minutes. You can do it at home. It's a simple saliva test. You can do it daily or nearly daily, every other day. These can be quickly mass produced. They're very easy to make. It's almost kind of like printing, and you can print it out. And it's sensitive enough to detect the virus that causes COVID. The PCR test, however, and you get results 1 to 7 days on that. It's not self-administered. You have to pay somebody else to do the test. It's not realistic to do it frequently because, again, it does cost some money. If you're the NBA or if you're other sports team, you can do that. Or if you're a high-end university, you can do that. It's limited in the mass product. Right now we're seeing bottlenecks. That little swab that they put up your nose, those are hard to get. And so who gets those swabs? How do we do those swabs? And so there's lots of materials that we see in here. Now, if we look at here, what this is slide here is showing you, this is from Michael Minna's talk as well, is on the bottom of this graph, we look at days since exposure. Okay. And then on the left-hand side of the graph, we look at the viral load. That's how many viruses looking at PCR you're going to have, not necessarily any other test. For the PCR test, typically you see the results of that test. You will only see the results of that test when you have roughly about 100 viruses per milliliter. For the paper antigen test, you need about 10,000, maybe 100,000 viruses per liter. In the progression of that, we see that those paper antigen tests will work roughly about a day after the PCR test. But again, it's still accurate. If we look at this, the virus is transmissible. One virus doesn't necessarily cause an infection. You need almost 10 to the 6th viruses per mil in order to be infective. And so what we see, these rapid paper antigen tests can actually test you before your period of transmissible virus. And so if you get tested every day, you're going to see this. For the RT-PCR test, and then even if you can't see the results for that test over 7 days, and so if you do the RT-PCR test right when it's viable at day 2, and you have to wait 7 days, 9 days, that virus has actually had a long time to get to the other patient rather than you. And so because we're testing every day, it's a very cheap test, it's a very fast test, we're testing every day, it doesn't matter if it's not as precise as the RT-PCR test. Michael Mina, CDC, is mainly wanting us to do the accurate test because, yes, it is more accurate, it's more expensive, and it's harder to do, and you don't get the results next in time. And so it would be just as good. So as a absolutely most effective, is it there? No. But is it cheap and easy to use? Yes, it is. And so the idea is actually what Michael Mina and a number of other people want people to do is kind of write their senators and governors and say, you know what, we don't need to have an absolutely precise test. We need to do testing very often. And so again, what I'm talking about here is looking at a diagnostic versus public health intervention. And so that diagnostic tests are anywhere between 70 and 90% accurate. And even though a public health test, a paper strip test, is only 50% accurate, because you're doing it every day, you're going to have it. And so again, we need to see, does this pass muster with the FDA? So fast, cheap tests will enable us to have safer reopening. And this was from an article in Science Magazine on August 7th. And so in a July 31st JAMA Network open article, they developed an algorithm where they looked at 5,000 students in a small university. If we have a 70% effective test and you have a 90-day semester, if you test every other day during that semester, basically, if you start out with 10 cases, if you start out 1 case, maybe you'll get 10 cases in this model. If you do PCR every week, you're going to have 108 cases. There's going to be a lot more. And this cost of the testing for 5,000, just do kind of your regular addition, et cetera. If we test every 3rd day, if we have 5,000 students, we have a 90-day semester, that's going to be 150,000 events per day. And imagine 150,000 tubes and stuff like that. So you want to have something small so it doesn't affect the environment as well. But we have these 150,000 events. If you do a test that costs $1, then that's $150,000. Well, that is expensive. Imagine if that test is $100. If it's $10, it's going to be 1.5 million. It's $100, it's going to be 15 million. And so that's way too expensive for us to be able to do. Again, a school of 5,000 students is not going to be able to afford that, but it will be able to afford these kind of cheaper tests. And basically, we're looking at something less than a cup of coffee a day. Can we test our way out using these cheap and easy and fast tests? Kind of, yes, we can. And so I really strongly encourage you to actually write letters to your senator and everyone else saying we can do these fast and easy tests. Until we get a vaccine, we can't just sit at home until we get a vaccine. And maybe we even don't need, it's not that imperative that we have a vaccine to do that, as long as we do those cheap and fast and very often tests. That's it for today's talks, folks. At the PDA, we are connecting people, science, and regulation. Make a connection and encourage somebody to wear a mask. The science of the COVID is evolving, but we need to keep on to this. Will we have a new regulation being able to use these fast and easy tests rather than the most accurate test? All right, that's it for me today. Thank you very much, folks.